Hello, I'm Nicholas Cohen, and I'm here to share with you an overview of the care of the type 2 diabetic adult, the basics. The objectives of this talk are to understand the focus of this training, to learn about goals for diabetes care, and to become familiar with specific recommendations for the monitoring and treatment of diabetics. The focus of this training is to train healthcare trainees, such as nurse practitioner students, to co-manage a patient with a team of healthcare professionals, including a physician, pharmacist, nutritionist, diabetic educators, ophthalmologists. The focus of these guidelines that I'll be discussing is on type 2 diabetics in distinction from type 1 diabetics. I will only be talking about type 2 diabetics in terms of management. I will not be talking about screening for diabetes in the general population, or preventing diabetes in the general population, or preventing diabetes in patients with prediabetes. The talk will only be focused on adults. We will not cover care of children, and the only adults we'll be discussing are non-pregnant adults. The source of the information I'm presenting is the 2013 Diabetes Care Guidelines by the American Diabetes Association, up to date, which was accessed in March 2013, the American Association of Diabetic Educators, and my 3 years of experience in practice. The first thing to know is the diagnostic criteria for diabetes. All of these tests except the last one require a repeat testing, so the only one that doesn't require repeat testing is if someone has the classic symptoms of hyperglycemia, like increased eating, increased urination, blurry vision, and they have a random glucose, or a glucose that's checked without fasting, that's greater than or equal to 200. Those patients have the diagnosis of diabetes, do not require repeat testing. All the other testing that defines diabetes requires a repeat test. This includes the hemoglobin A1C of 6.5 or greater, a fasting plasma glucose of 126 or greater, with fasting defined as no caloric intake for at least 8 hours. And lastly, a 2-hour plasma glucose during the oral glucose tolerance test. This is using a 75-gram load of glucose dissolved in water and checking the sugar at 2 hours after the glucose test. It should be less than 200. If it's 200 or greater, this is one of the criteria for diabetes. So what is the goal for diabetes, for managing glycemia? The goal is 7%. 7% is the goal for most people with diabetes. 7% hemoglobin A1C. However, there are going to be populations where the goal is going to be different. For example, in someone who's recently diagnosed and a younger patient, you might have a goal of less than 6.5. These are in patients who have not had history of hypoglycemic episodes, don't have a lot of comorbid conditions, and generally are not very old. So the other option is a hemoglobin A1C of less than 8%, and that's basically in the patient I described just now, the patient who's older, who has a lot of comorbidities, a lot of different illnesses that they're dealing with, or has had significant hypoglycemia or low sugar in the past. Those patients you might decide on a goal with them, in discussion with them, of less than 8%. So again, less than 7% for most people. If you want to be more aggressive and the patient is younger and doesn't have a significant history, then a goal of less than 6.5. And then if the patient does have a higher risk of problems and is older, you may consider a goal of less than 8%. So how often should the hemoglobin A1C be tested? Typically, if you have good control, if you're at your goal, then you'll want to test at least every 6 months. If, however, you're not at your goal, then it makes sense to check every 3 months. It doesn't make sense to test more frequently, as the hemoglobin A1C is a reflection of your sugar for the past 3 months. So every 3 months is the most frequent you want to test. Now, the next issue is how often you should be telling patients to check their sugars. This really depends on their level of glycemic control and what medications they're on. And this is, I'm giving you here my recommendations. These depend on who you ask. I would recommend that if the patient is just taking an oral hypoglycemic agent, they don't need to check their sugars at all, or most they might do it once or twice a week. If the patient is using a long-acting insulin such as Lantus or Detemir, I recommend that they check their sugars once before breakfast. And then if they're using an insulin that is dosed more frequently, such as an intermediate insulin like MPH or a short-acting insulin, then I would recommend having them check their sugar before administration of any of those insulin. So if you diagnose diabetes, the first line treatment is metformin. Metformin should be started at the time of diagnosis of diabetes, and it should be continued even if you start someone on insulin. The typical reduction of A1C on metformin is 1.5%. It should not be used in patients with renal insufficiency, which is defined as, in females, a creatinine of 1.4 or of greater than 1.4, and in males a creatinine greater than 1.5. Any condition that would predispose the patient to have decreased tissue perfusion is also a contraindication, as decreased tissue perfusion in patients with metformin can lead to lactic acidosis. One condition in particular is alcohol abuse. Others will suggest that in liver disease and in heart failure, metformin is contraindicated, but there's less of a consensus on those two conditions than there is on alcohol abuse, where it is contraindicated. Metformin commonly causes gastrointestinal side effects and decreased appetite. It's better to start slowly and to go up gradually. The pill should be taken before meals. It's recommended that you start at 500 milligrams before dinner, and then over the next month or two increase to 500 milligrams before breakfast and then before dinner, so twice a day, going all the way up to 1,000 milligrams before breakfast and 1,000 milligrams before dinner over the next 1 to 2 months. The dose of metformin should be increased up to 2,000 milligrams or 2,500 milligrams, but only as the patient can tolerate it, and as high as the patient can tolerate. Glipizide is the other important oral medication to lower or to improve diabetes control. It can be used as a first-line agent. Glipizide is a sulfonylurea. It's short-acting, so it's actually one of the safer of the sulfonylureas, because sulfonylureas as a class can cause a low glucose, and a low glucose is less likely with the shorter-acting forms, which is glipizide. So glipizide can be started at the diagnosis of diabetes in patients who have a contraindication to metformin. It can also be added on to metformin if after 3 months of being at the maximum dose of metformin, the patient's hemoglobin A1C is still not at goal. Again, side effects of glipizide include low sugar, hypoglycemia, and patients should be instructed on what to do if they do develop, and of what hypoglycemia looks like and what they should do if they develop hypoglycemia. I tell patients to drink a cup of orange juice and to recognize hypoglycemia as being dizzy or lightheaded or having blurry vision. Another side effect to have patients be aware of is weight gain. And Metformin actually is good at balancing against this effect, as it has been shown to be weight neutral or even help with weight loss in some cases. The dose of glipizide is 2.5 milligrams. It should be given 30 minutes before breakfast. It can be increased over the next few weeks or after a month to 5 milligrams 30 minutes before breakfast, and then to 10 milligrams 30 minutes before breakfast, with a maximum dose of actually, well, a maximum dose is actually 40 milligrams a day, but I'm not sure that there's much benefit at that high of a dose compared to 10 milligrams in the morning and 10 milligrams at night before dinner, which is a commonly accepted maximum dose, 10 milligrams BID before breakfast and before dinner. And if you are unable to achieve your A1C goal on those 2 oral agents, then after 6 months of being on those maximum agents, or even sooner, you may consider starting insulin. You may also start insulin if the hemoglobin A1C at the time of diagnosis is greater than 10%, as it's unlikely that oral agents alone will be able to lower the A1C to the goal. If you do decide on starting insulin, it's important to stop glipizide. You can continue metformin, but glipizide plus insulin leads to too high a risk of a low sugar. I recommend starting with either Glargine or Detemir, Glargine being Lantus, or Detemir. Both of them are long-acting, at bedtime at approximately 10 p.m. and at 10 units. The patient should then be instructed to check their sugar at about 7 or 8 a.m. and should check their sugar every morning and take the dose every night at 10 p.m. They should be instructed either to come in frequently or to have insulin adjustments, or to have adjustments done with the help of a healthcare provider over the phone, or to do the insulin adjustments on their own, depending on their ability to express understanding to you and your confidence in their ability to adjust their insulin on their own. I find that doing the teach-back method, where you explain to the patient a titration plan that they would do at home, that the teach-back method, to see if they understand how to manage their sugar, is an effective way for you to judge whether it would be safe for that person to be adjusting their insulin on their own. However it's done, it's recommended that the insulin dose, the long-acting insulin dose, be increased by 2 units every 3 days, as long as the glucose level, and that's before breakfast, is greater than 130. If the glucose level is less than 70, then it's recommended that the insulin dose be decreased by 40 units. The next area of discussion is weight loss for diabetics. So it's important to refer diabetics to a nutritionist for medical nutrition therapy. The guidelines don't specifically say how often a nutritionist should be consulted, but I at least would recommend at the diagnosis of diabetes, and perhaps every year, depending on the patient's interest in changing their diet. Bariatric surgery is recommended in patients with diabetes who have a body mass index of 35 or greater. So I would make that referral soon. In many institutions, such as the one I work at, they have a lot of resources to help patients lose weight, even if they're not candidates for bariatric surgery. So it's a good idea to get them plugged into those systems. The goal is to encourage all patients to achieve a body mass index of less than 25. I recommend giving patients a 10% weight loss goal, to give them the actual pounds and the actual date that they would achieve that goal, and to recommend that they start working to achieve that goal by first getting an idea of how much food they're eating every day. People who eat throughout the day or don't eat regularly scheduled planned meals tend not to even know how much food they take in. So starting to think ahead about meals and confining the times that you eat to 3 times a day, where you sit down and you eat food on a plate, is an effective initial strategy for getting people to understand how many calories they're taking in. It's also recommended that patients walk or do some sort of moderate intensity activity for at least 30 minutes a day, and if patients are obese, at least an hour a day, and do that most days of the week, if not all days. If you have a weight loss goal of 10% over 6 months, this can be translates into a goal of a pound a week approximately. And I encourage patients to buy a scale, to weigh themselves weekly, to write down their weight on that scale, and to aim for this goal of 1 pound of weight loss per week. If they are not meeting that goal, then they should think of a pound as 3,500 calories. And with 7 days in the week, there's 500 calories a day will lead to a pound of weight gain or a pound of weight loss. So if you explain to patients who are not losing a pound a week to start subtracting from their diet 500 calories a day, this can be an effective tool for helping them achieve a pound a week of weight loss. The next area of discussion is blood pressure control. It's important for diabetics to maintain a blood pressure of less than 140/80. There is an optional goal of less than 130 systolic blood pressure, and this is especially good for patients who are younger. If a patient is diagnosed with high blood pressure, it's important to start them on an ACE inhibitor or an ARB as a first-line medication. ACE inhibitors typically end with pril, like captopril, benazepril, lisinopril. ARBs typically end with tan, losartan, candesartan, olmesartan. It's important to know that these medications are teratogenic, so women who are of reproductive age should be counseled to use contraception, and if they do become pregnant, to stop taking the medication. Patients who are started on this medication should have their creatinine function and their potassium checked annually. Also, anybody with high blood pressure and diabetes should be referred to a nutritionist for a DASH diet, dietary approaches to stop hypertension. This diet has been shown to effectively reduce blood pressure in patients with high blood pressure. Sodium goals in this diet are less than 1,500 milligrams per day. Patients should be instructed to eat 8 to 10 servings of fruit and vegetables a day, 2 to 3 servings of low-fat dairy, and to limit alcohol in men to less than or equal to 2 alcoholic drinks, and in women to less than or equal to 1 alcoholic drink. The next area of discussion is tobacco use in diabetes. Tobacco use should be screened for in all patients at every office visit. When I counsel patients, when I find out that someone has a history of smoking, I'll first ask them, before I even get into the question about their desire or whether or not to quit, I'll just gather more information, asking them if they've tried gum before, if they've tried the patch, if they've tried any medications, if there's been any time that they quit on their own. And then I'll make this strong statement to them. I'll say that quitting smoking today is the most important thing you could do for your health. And I'll say to them that it's extremely hard to quit. It takes people at least 5 times to get it right on average. And that there are medications and nicotine replacement products that make it easier. And that I would really like to work with them on this goal. I say that there are many options we could try, and if they don't work, we could try another. And then I ask them, how interested are you in trying one of these options? I find that this strategy is more effective than assessing someone's readiness to quit, because I think that if the patient thinks that this is going to be there's a lot depending on them to quit, or you're going to be upset with them if they don't quit, then they're less likely to be ready. And so preparing the field by describing it as something that's kind of a very low stakes consideration and something that you want to work on with them on together, I think increases their readiness to quit at that moment. And then getting them to just sort of want to start or try medication and thinking of it as not as the end-all be-all, but as just one attempt out of potentially many, and trying to choose and find the right medication instead of digging into their readiness, I think is more effective and takes the pressure off. So we'll talk about the different options, and then I'll recommend that they set a quit date. I'll schedule a follow-up with them either by phone or in person about a week after their quit date, and I'll say that that's to see how you're doing. If you weren't able to quit, we'll work on another plan. If you were, I'll congratulate you and see if you need any other advice. And then I'll give them the 1-800-QUIT-NOW number, which provides counseling 24 hours a day for people who are trying to quit. So when you encounter someone who is interested in smoking, there are several options. And I suggest covering them all with the patients and then saying that it's good to try another if one doesn't work. So the patch and the gum is my first line recommendation, partly because although Chantix is more effective, there's also more side effects, and I tend to want to try something that will have a less likelihood of side effects first. So if the patient is smoking 10 cigarettes, more than 10 cigarettes per day, it's recommended that you start with 21 milligram patch per day, and they just wear this for 24 hours and then replace it with the next patch. They do this for 6 weeks. Then the dose is decreased to 14 milligrams a day for two weeks, and then 7 milligrams a day for 2 weeks. If patients are smoking 10 cigarettes or less, then we'll start at a 14 milligram per day patch for 6 weeks, and then we'll do 7 milligrams per day for 2 weeks. In addition to patch can also be done alone as well as gum alone, but the combination has been shown to be even more effective in the literature. The gum that I recommend is a 2 milligram piece. These are for patients who are smoking less than 25 cigarettes a day. For more than 25 cigarettes a day, you could try the 4 milligram piece. So the patient should chew one piece of gum every 1 to 2 hours for 6 weeks. And it's important to use at least 9 pieces of gum every 24 hours for the first 6 weeks. The way to do this is tell them to chew it, and then after about half an hour, when they start to get the taste of the nicotine, to park it. Park it in their buccal mucosa, and then when the taste has gone away, to chew it again. But the idea of parking it and then chewing it again is an important concept to teach patients. After the first 6 weeks of one piece of gum every 1 to 2 hours, then go to 1 piece of gum every 2 to 4 hours for 3 weeks, and then 1 piece of gum every 4 to 8 hours for 3 weeks. The options for pills to take for smoking cessation are varenicline or Chantix. I avoid this medication in anyone with a history or current depression or any psychiatric disorder, but definitely there's an FDA black box warning if the patient has a history of suicidal ideation. This is the most effective medication, but again, it requires screening for psychiatric disease before starting it, and explaining to patients that it can cause nightmares as well. So the dose is 0.5 milligrams daily for 3 days, then increased to 0.5 milligrams BID for 3 days, then increased to 1 milligram BID for a total of 12 weeks. Bupropion, or Zyban, is given, it actually takes a week to build up. So you start at 150 milligrams daily for 3 days, then you take it twice a day for 3 days, and then for the remainder of the 12 weeks, you take it 150 milligram tablets twice daily. This medication is weight neutral or even helps people lose weight. So if a patient is very concerned about gaining weight after quitting smoking, this is a good medication. Also, patients with history of depression, bupropion is an antidepressant, so this can be helpful in those patients. Bupropion does lower the seizure threshold, so it should be avoided in patients with a history of seizures as well as patients with a history of eating disorder. Cholesterol control for diabetes. A fasting lipid profile should be checked every year in patients with diabetes. If patients have very low risk cholesterol profiles, specifically an LDL of less than 100, as well as an HDL greater than 50, and a triglyceride less than 150, then spacing out to every 2-year lipid profiles is acceptable. The goal for cholesterol control in diabetics is for LDL to be less than 100 for most patients. And then there's an option for very high-risk patients to have a goal of LDL less than 70. This is from the ATP3 2004 update on cholesterol management, and it describes what patient population could have an optional goal of an LDL cholesterol less than 70. Specifically, they describe very high-risk patients as having established coronary heart disease plus multiple major risk factors, especially diabetes, or established coronary heart disease with severe and poorly controlled risk factors, especially continued smoking, or established coronary heart disease plus multiple risk factors of the metabolic syndrome, especially triglycerides greater than or equal to 200 plus non-HDL greater than or equal to 130 plus HDL-C less than 40, or established coronary heart disease and acute coronary syndrome. If a patient does not have a family history of coronary heart disease or doesn't have a personal history of hypertension, smoking, dyslipidemia, or albuminuria, then we call them lower risk. In those patients, we only use a statin if their LDL is not at our goal of 100. In addition, statin medications are recommended regardless of whether or not their LDL is at goal, if the patient has a history of cardiovascular disease or acute coronary syndrome, or if their age is greater than 40 and they have cardiovascular risk factors, such as a family history of cardiovascular disease, which is in a female age less than 60, a first-degree relative, or a male less than age 50, first-degree relative, if the patient has a history of hypertension, smoking, dyslipidemia, or albuminuria. And it's important to remember that a statin medication is teratogenic, so women should be counseled that they need to use contraception when taking a statin medication, and that if they become pregnant, to stop that medication. Lifestyle modification is an important adjunct to lowering cholesterol. Patients should be encouraged to lose weight if indicated, to increase their physical activity, to stop smoking, to reduce saturated fat, trans fat, and cholesterol, to increase omega-3 fatty acids, to increase viscous fiber such as oats, legumes, and citrus, and to increase plant stanols and sterols. We're now going to discuss aspirin for diabetes. So aspirin is recommended for adults who are not on non-steroidal anti-inflammatory drugs and who do not have upper GI pain or history of gastric ulcers or duodenal ulcers. So those are contraindications to aspirin. Indications for aspirin are for men, calculate their cardiovascular disease risk or their coronary heart disease risk using a Framingham calculator. I have the link to one listed here. You'll enter their age, whether or not they have diabetes, their total cholesterol, their HDL cholesterol, their blood pressure, and whether or not they use tobacco to give you a 10-year CHD risk. You then would start aspirin if they are age 45 to 59 and their 10-year risk is 4% or greater. If they are 60 to 69 years, you would start aspirin if their 10-year risk is 9% or greater. And if they are 70 to 79 years old, you would start aspirin if their 10-year risk is 12% or greater. For women, determining whether or not to use aspirin is based on their 10-year stroke risk. All of these guidelines are from the United States Preventive Service Task Force. I have the link to a stroke calculator here. The stroke calculator will require you to enter the age, blood pressure, diabetes, if they have it or not, their tobacco use, whether or not they use tobacco, whether or not they have a history of cerebral vascular disease, whether they have a history of atrial fibrillation, and whether they have left ventricular hypertrophy. If a woman is age 55 to 59 and has a 3% risk or greater, 10-year risk or greater of a stroke, then aspirin should be started. If they are age 60 to 69 years with an 8% stroke risk or greater, they should be started on aspirin. And if they're age 70 to 79 with an 11% risk or greater, they should be started on aspirin. And typically, aspirin 81 milligrams is the preferred dose. Foot care in diabetes. I recommend referring to podiatrists if you have any concerns about a patient's foot, including any kind of foot deformities or any kind of decreased sensation or need to have fittings for orthotics or special shoes to wear. It's important to recommend that diabetics never go barefoot, even in the house, that they always wear shoes, that they wear shoes that are comfortable and fit their feet, that they always wear socks, that they change their socks every day, that they keep their feet clean, that they make sure that their toenails stay trimmed, that they inspect their feet for skin breakdown every day, and that they make sure that when testing hot water, if about to step into a bath, they test the hot water with their hand, because they may not feel if the water is too hot on their feet. A foot exam should be performed by a healthcare practitioner at least annually. It should involve inspecting the skin, assessing pulses, and testing for loss of protective sensation. And this should be done with two modalities. One is the monofilament test, and then one other modality. So monofilament plus one of the following. A tuning fork at 128 hertz for vibration sensation, testing pinprick sensation, and testing an ankle reflex. Any of those three, in addition to monofilament, meet the requirements for the annual foot exam. There are 3 important immunizations for diabetics. They include an annual influenza vaccine, and it should not be the intranasal vaccine because for diabetics. The pneumococcal vaccine should be given at the diagnosis of diabetes or whenever it can be given before age 65, and then again it should be given at age 65. It should not be given within 5 years of the last one, so if you have given the patient a pneumococcal vaccine between age 60 and 65, you should wait 5 years until you give them that booster instead of giving it at age 65. And then the hepatitis vaccine, this is a new recommendation for starting in 2012, that all patients who are not immunized to hepatitis B should be given the hepatitis B vaccine. It's important to refer all patients yearly for a dilated eye exam. And it's important for patients to receive diabetic self-management education. This can be best performed by a diabetes educator. There are 7 essential components, according to the American Association of Diabetic Educators, for diabetes education. They include discussions about physical activity, healthy eating, taking medications, monitoring blood glucose, diabetes self-care related problem solving, reducing the risk of acute and chronic complications, and psychosocial aspects of living with diabetes. This concludes the talk on diabetes care. We've covered monitoring of diabetes and active management to improve diabetes care. I hope this video has been helpful. Thank you for listening. Have a great day.